Respected chairperson, a very good morning to each one of you. I thank the organizers of Clinic 2024, Dr. Deepak, Dr. Bhavani, and the entire team for giving me this privilege. So next 15 minutes, I shall be talking about the hyperammonemia sources and solution. And to a large extent, Dr. Pawan has eased my job because some overlap will be there. Greetings from AIG Hospital. Ours is a 800-bed tertiary care center, and we as a team manage a surgical critical care 64-bed unit. Nil conflict of interest. I will not be discussing about the pediatric causes or the inborn errors of metabolism because that is one of the important causes of hyperammonemia in kids. Why are we discussing this topic? As has been said by Dr. Pavan, hyperammonemia in hepatic encephalopathy or even non-hepatic cause of encephalopathy is a major cause of ICU-related encephalopathy or disturbances or ICU delirium, one of the cause. And if left untreated, it can lead to severe morbidity or sometimes mortality also. And importantly, it can occur in critically ill patients. Most of the ICU patients, they have some sort of neurological imbalance. And importantly, as an intensivist, we need to know the causes, both the hepatic as well as non-hepatic causes, so that we can give a targeted therapy because if left untreated, it can endanger the patient's life. So the aim of my talk is to discuss the different causes, the sources, and appropriate therapy to be targeted so that we can enhance the patient outcome. So when we discuss about the etiology or the sources of hyperammonemia in the ICU, it is the diseases that increase the production of ammonia, like intestinal causes, muscular metabolic causes, infections, or sometimes where the clearance of ammonia is impaired, like patients with kidney diseases, hepatic dysfunction, which is the most common cause in our ICU, or the inborn errors of metabolism, or sometimes complex multifactorial mechanisms like patients undergoing lung transplantation surgery or sometimes bariatric surgery because the milieu interior is altered. Importantly, because the focus and the commonest cause is still hepatic encephalopathy is the commonest of hyperammonemia, we tend to undermine, disregard the non-hepatic causes, which has to be on the radar because they are very difficult to treat. The basis of production of ammonia, we all know the urea cycle, and I don't want to go into the details, but we need to know that the urea cycle has a mitochondrial component of metabolism and the cytosol component, and the enzymes and the deficiency at various level can lead to increased production of ammonia, which can be deleterious. And then discuss about the production of ammonia and clearance of ammonia. We know that ammonia molecule is metabolized in various organs, the skeletal muscles, the kidneys, the intestines, the liver, of course, as the urea cycle, and importantly, into the brain also. And production of ammonia in the brain or metabolism into the glutamate also itself is a neurotoxic molecule, and we need to understand because each one of these can impair and can production of ammonia is increased and can have deleterious effect on the brain, which is the most target organ. So what happens in the brain? Basically, the astrocyte has been said by Dr. Pavan, it metabolizes ammonia into glutamate, which again is a false transmitter, and it can increase the neuroinflammatory response, which can lead to raised intracerebral pressure, the cerebral edema, and eventually herniation and death if the things are not taken care of. And we need to know that at various levels and various organs, the things can be impaired. Musculoskeletal system is a great buffer for ammonemia, but in cirrhotics, again, the muscle mass is reduced because of sarcopenia, and again, production of ammonia or metabolism of ammonia is impaired. Similarly, in hepatorenal syndrome, where the kidney function is impaired, both the acidosis, which increase the production of ammonia, and alkalosis, which increases the absorption of ammonia to the circulation, are deleterious. So delving into the various causes of hyperammonemia, mostly it could be categorized into those, as I said, that increases the production, the nutritional, the enteral causes, where which you see in typically catabolic states like acute pancreatitis, burns, trauma, or sometimes you see when the gut microbiome is altered for absorption of the intestine, or hyperalimentation when you're giving more proteins to the patient who are sarcopenic, like 2.5 grams per kg per day, and all these things can produce ammonia. Sometimes the production of ammonia can be infection mediated, especially certain bugs which produce urease enzyme, and that decreases the clearance of urea. So typically the organisms are ureaplasma, Proteus mirabilis, Morganella morgani, Klebsiella pseudomonas, so on and so forth. But importantly, most of these organisms, they deplete arginine, which is a cofactor necessary for urea cycles. Certain oncologic conditions like multiple myelomas, leukemias also enhance the production of amino acids which are not metabolized, and they can lead to hyperanemia. And muscular causes, as I said, muscle is a great reservoir. But importantly, after a tonic and clonic seizure, the ammonia can go as high as 40 to 500 micromoles per liter. But fortunately, if the liver is functioning well, they clear off within 2 to 3 hours. So you just have to keep this in mind. Certain metabolic disorders like enzyme deficiencies, urea cycle can lead to hyperammonemia production. But importantly, drug induced. There have been many case reports where common antiepileptic medications like valproate have led to hyperammonemia production. Carbamazepine, topiramate are less, but they can also impair. Basically, the metabolite of valproate acts at the CPS level 1 in the mitochondrial level of urea cycle, and it imparts or retards the urea production of urea and the clearance of urea. Halogen anesthetics, inhalation anesthetics like halogen and fluorine also have been employed in animal studies, but fortunately there are no human case reports of inhalation anesthetics causing hyperammonemia. Gabapentin, salicylates, and other and immunosuppressants like tacrolimus, cyclosporin, acetazolamide, so on and so forth also can cause that hyperammonemia. You have to keep in mind, especially when you're evaluating or when you are clueless about what is the cause of hyperammonemia. Renal causes, yes, we all know acute and chronic kidney diseases because they reduce the absorption of ammonia, increase the absorption of ammonia, and sometimes they increase the production of ammonia also. Portosystemic shunting also already has been mentioned upon, can also increase hyperammonemia. But importantly, patients who undergo pelvic exenteration, like malignancy of bladder or nephrouretic radical surgeries, they end up with ureteric reimplantation with either as an ileal conduit or into the sigmoid, and you are bypassing the stomach, and sometimes you are ending up with hyperammonemia. So you just have to keep in mind because it can be procedure specific. Similarly, bariatric procedures, especially Roux-en-Y anastomosis, can cause hyperinsulinemia. They alter the bypass again from the guts and from the liver, and can also induce hyperammonemia. So basically, the point which I want to emphasize is there are multiple causes, the hepatic and non-hepatic causes, which you need to keep in mind so that we can give targeted therapy. So once you know the etiology, how do we assess the patient and what are the laboratory parameters? Again, you need to remember that the laboratory parameters, there can be a lot of sampling artifacts that can happen because to measure ammonia, you require a fresh sample taken from a large vein like a central vein or easily drawn blood, because if you are squeezing the blood from a small vein, hemolysis itself can cause pseudo rise in ammonia level. And once the level is drawn, the plasma has to be centrifuged so that you can separate and you can obtain the true result. And if you don't carry the sample in a cold chain, preferably in an ice chain or an ice cube chamber, again you may have pseudo increased level of levels of ammonia. So you have to keep this in mind, and you need to have a protocol of minimizing sampling artifacts. And you can minimize this thing. And similarly, other assays also can be done. The plasma level assays, the certain assays, all assays are available in our country, in our state also, in our hospital also, but they come at a cost, and but this can be done. But importantly, you need to remember that serial arterial ammonia level measurements are the stay, because the ammonia levels have to be monitored, especially when you're treating the patient or when the patient clinically does not improve. So the laboratory assessment should be, in addition to measuring ammonia levels, you need to do a routine biochemistry, the blood gases to know the acid-base status, and you need to do the infectious workup also. And similarly, if the patient on antibiotic medications, you need to measure the level so that we know we can give a targeted therapy. The levels, we all know the reference levels in adults, male and females. But importantly, if the levels are high, then we have to start treatment. And the treatment, what are the implications of raised ammonia? As again has been said by Dr. Pavan, Hepatic failure, we see ammonia as high as sometimes 250 or 300 micromoles per liter. And there have been cases of cerebral herniation in patients with typically with 150 micrograms per liter levels also. Even though most of the studies they say the levels of more than 250 are more responsible for cerebral herniation, but there have been case reports where as low as 150 can lead to cerebral herniation. So treatment has to be very, very prompt and very aggressively. In acute liver failure, again, the treatment has to be appropriately targeted because we know that encephalopathy, edema, and ACP elevated, elevated ICP can lead to metal mortality, patient mortality. And acute liver failure also has been associated with extrahepatic organ dysfunction. Typically the supportive care is nothing but the timely diagnosis and is very crucial, and general critical care neurosupportive measures have to be done in all the cases. But most importantly, if the patient with cerebral irritability throws a fetal seizure, is it because of hyperammonemia leading to seizure or seizure causing hyperammonemia? So you need to have fine line of detection. And as I said, if it is a totally clonic seizure causing hyperammonemia, it clears off within 3 to 4 hours. If it doesn't clear off within 3 to 4 hours, then you need to probe into non-hepatic causes. The strategies for clearing ammonia from the patient circulation is reducing endogenous production. So enhancing kidney function, optimizing acute kidney injury, correcting hypovolemia and other things can increase the ammonia clearance via kidney. But importantly, exogenous clearance is what we as an intensivist are fond of doing it if the patient do not respond to conventional measures. And conventionally, the renal replacement therapy, intermittent hemodynamic dialysis, intermittent hemodialysis is very, very effective in reducing plasma levels. But the pitfall of this way of dialyzing the patient is it reduces the plasma levels of ammonia, but can cause cerebral rebound because the cerebral level of ammonia do not reduce. So IHD is not a good option in the patients who have hyperammonemia induced cerebral irritability or cerebral involvement. And CRRT is the methodology of choice, and CRRT over a period of 24 to 30 to 48 hours, it what reduces the level of ammonia right from the plasma as well as from the brain, and it carries less risk, and you can correct the electrolyte imbalance if at all it happens during the treatment. CRRT also is helpful in hepatic cause of hyperammonemia, and there have been cases where even patients having lung transplantation, this CRRT has helped. And the other modality is the plasma exchange, plasmapheresis. It also helps in reducing levels of ammonia right from the both from the brain as well as from the peripheral circulation. But it is important to know that whenever you're giving plasmapheresis or plex exchange, the CRRT has to continue for a longer time, because at the end of the day, rather than the duration of rather than the type of therapy, the duration is what is important, and slow and steady definitely it helps in clearing ammonia from the cerebral as well as the peripheral circulation. Bowel decontamination has already been mentioned. Rifaximin 550 milligrams twice daily, metronidazole, neomycin, and acidification of gut microbiome with the lactulose, they offer benefit. But importantly, in non-hepatic cause of hyperammonemia, they don't offer much benefit. Hepatic encephalopathy, definitely it helps. Similarly, lactulose, as I said, it reduces the production of ammonia. It converts ammonia into ammonium, which is poorly absorbed, and it helps in improving gut microbiome also, and reduces the production of ammonia. But again, lactulose doesn't have any role in managing non-hepatic cause of hyperammonemia. Metabolic scavengers like GLOLA has been mentioned. It helps in hepatic cause of hyperammonemia, but non-hepatic causes doesn't help. Zinc deficiency, as has been mentioned, it's a coenzyme required in urea cycle, also helps in treatment of hyperammonemia. Empiric therapy, especially for non-hepatic causes of hyperammonemia, empiric therapy, especially when you're suspecting infection as a cause, especially post-lung transplantation, and this thing can be of use. And the conventional antibiotic may not be of help, and the antibiotic which have been studied maximally are the atypical coverage like tetracycline and levofloxacin. But before you start this antibiotic, better to send the PCR-based diagnostics so that you can target appropriate therapy and you can prevent antibiotic abuse. Similarly, hyperalimentation, if it is a cause, then go for 10% dextrose containing fluid, and you can reduce protein intake. But importantly, in a cirrhotic patient, reducing protein intake also is the double whammy, and you need to titrate these therapies. Patients who do not respond to standard therapy, then you need to subject them to portosystemic shunts. And importantly, if nothing works, then liver transplantation has to be considered, especially if the cause is hepatic origin. And when we are discussing about the medical management of hyperammonemia, not to forget the general ICU management and multi-organ supportive therapy, because this patient always will have multiple organ dysfunction syndrome, and you need to optimize various functions. Just to share our data, last 2 years data, we had 96 cases. Most of them were hepatic etiology, being a GE center predominantly. But importantly, the sepsis causes also were there, and majority of them were post-necrosectomies, pancreatic necrosectomies were the causes. Two patients required CRRT for almost about 6 days, but there was one mortality, ultimately because of multi-organ dysfunction syndrome. So to conclude, I would say that the liver failure is one of the commonest cause of hyperammonemia, and it is associated with worst neurological outcomes. Serial arterial ammonia monitoring may help us to minimize the risk and complications associated with hyperammonemia. And for hepatic encephalopathy or liver-related issues, the decontamination of bowels and lactulose helps. And for non-hepatic causes of hyperammonemia, you need to evaluate an appropriate therapy has to be targeted, and this has been emphasized by earlier speaker also. Thank you very much for the opportunity. Before I conclude, last slide, I invite you all to our hospital for the first conference on perioperative medicine, which is being held in 22nd and 23rd March. We have interesting workshops lined up, and we'll be happy. The registrations are on. Thank you very much. Thanks, Jacob.
Thank you, sir. We'll take the questions at the end of the other two.